All right. Today we are going to be talking about activity screening. So far we have talked about and either done some kind of work about your vision statements and your mission statements, your bloodborne pathogens plan, your emergency action plan, your budget, and your floor plan. So you should have at least some semblance of some of this done. I implore you again, if you don't have all of those things on paper, that you get there soon, because we're already in week 8, coming on week 9, there are still a bunch of elements. I don't want you to be the person that's getting bowled over by the ball by week 12 or week 14. So you know, at the end of the semester, you've got exams, and you're going to have projects, and you're going to have presentations, and you don't want to be working on your manual in a fury. You want to be working on it, but not in a fury of, I got to get stuff done. Because I was just talking to somebody else in one of the other classes, and they're like, I have little bits and pieces about the different projects on paper, but I don't have that much finished. And what happens is, if you're like me, you work for the deadline that's today. So if you have an exam today, you're studying for the exam today, and then the O&A stuff kind of starts to fall by the wayside because there aren't any hard deadlines for each of those projects except for the ones that you're turning in. So this is just a friendly reminder, because the next thing that you're going to be moving to or working on are going to be your activity screening. So every time that we have a different topic in here, it's going to be an additional piece of work for you to start working on. Okay? So we're going to talk about activity screening, and we're going to talk about medical records today, which is going to eventually lead us into talking about healthcare, which is a huge topic. I mean, we'll probably spend almost a month talking about medical insurance, health insurance, different types of plans, different billings and codings, along with some speakers to supplement that. Because pretty much everybody in here is going to be working in some kind of healthcare. Whether you're billing for healthcare or not, you're still, either you have insurance, or you hope to have insurance, or you have parents, or brothers and sisters that have insurance, or you're going to be working there. So it's all a very good relative discussion, particular to professionally where we're going to be. So, what is the first thing that you need to know about medical records? Before we talk about anything else about what's contained in them, what kind of information is in there, who retrieves them, how we get them, what's the first thing you know about medical records? Well, left side of the room. Where's my left side of the room? Anyone? That's right side. Taylor, thank you. They have to be confidential. Okay? Anything that is in any type of medical record about someone's medical history, about the medications they take, the doctors they see, the type of conditions they have, who they've seen, counselors, any information like that is privileged information, and that's one of the reasons why we have HIPAA, which is the Health Protocol Information Act, that says whenever you go to the doctor and they ask you to sign that HIPAA paper, that means that your information can only be shared with who you say it can be shared with. Okay? Particularly if you have a condition or if you have something that you don't want people to see, no matter what it is, whether it's Crohn's disease or whether it's nothing that people would consider sensitive, it's sensitive to you. So everything is confidential that comes into a medical record. The other thing, in the day and age of electronics, it does contain personal information like your address. Maybe you don't want people knowing where you live. And it also probably has some financial information in there too, whether or not you're on a payment plan, whether you've been sent to collections. That's information that most people don't want up there or out there along with other people. Currently, we are in the midst of a change in philosophy in terms of medical records. When we're probably about 50-50 in terms of people still using paper and people going to electronic medical records. And if you've noticed, whether you go to the doctor's office or whatnot, a lot of times now your nurse or your physician will be sitting there with the computer while they're going over your health history and all the information, and it goes right from there to the billing office. And what are some advantages of that? Having the computerized records and having the doctor sit there or the nurse sit there with the computer right in front of them. Anthony?
It's a quick search. If you need to just type in information and you can pull it up quickly.
Okay. I can open the file folder though right in front of me and get the same information.
If it's organized well.
What's that?
said if it's organized well.
Okay. Jeff?
Easily transferable, so if you're sending, like if you're referring a patient somewhere else, you can send that like, electronic document to whoever you're sending it to, like PT clinic or something like that.
Absolutely. That from either from a physician to PT or even from physician to physician. Absolutely. James?
Let's say it's metered, not having a bunch of papers.
Neither in terms of being able to read it. You don't have to worry about handwriting issues or not being able to interpret. If any of you have ever had x-rays, I'll give you a perfect example. My daughter fell at school and they thought she might have had a navicular fracture. So we went to the emergency room and they took x-rays right there. And because but because I said I was an athletic trainer, they let me come around back and actually see the x-ray on the computer and take a look at what it looked like. And they put her in a splint and sent us on our merry way, and they said, you know, she's not any better, follow up. So then we went to an orthopedic office to follow up, and as soon as we walked in the door, before they even took an x-ray, they pulled up her x-ray that had been exported from the emergency room onto the computer. So you could see what her first x-ray looked like, and then they took an x-ray in the office and uploaded to the computer, and you could see within about 10 minutes one picture right next to the other picture. And you could see whether or not there had been any changes over 2 weeks' time. So instead of having to, instead of having to go to the emergency room and pick up the hand x-rays and carry them to the physician's office and then have a look at it, was all electronically in her file right there. So one of the very cool things about that is sharing information, and the other thing is about being able to manage people's care, too. We talk about managing people on a continuum of care and being able to know what kinds of medications they're on, how much medications they're on, and whether they have any interactions. So certainly some very positive things about some electronic medical records. What are some disadvantages, some negative things about them, or possible negative things about them? Come on.
We get a virus.
Taylor.
Computer issues.
Computer issues meaning virus or
Crashing, losing all your
crashing, losing all your information?
information. Keeping it confidential.
Keeping it confidential with how much information have we heard about in the news that's gone financial? JP Morgan, Target, Chase, Home Depot. So pretty much all of us in here someone probably has our information at some point. They're just going to use it at some point. What about, where does it all go? Where is that? All around. Who knows where it goes? I mean, Utah, Silicon Valley. There's some, I'm assuming that there's some place that houses all of those servers that sit somewhere with all of that. Because supposedly it goes into the cloud or a cloud, whether it's the Apple iCloud or someone else's cloud. But that information still has to sit somewhere. Think that might be a terrorist activity someday? Try and find the cloud. It would certainly cripple us financially if that happens. So there are some positives and some negatives, but I think in terms of a society, we can't turn back the clock. It's the way we're going. It's going to be electronic with the advantages and with the advantages and the disadvantages. So most of you are probably somewhere in transition. In this class, you're going to create paper forms. I know that we are working with some of our classes to get an electronic medical record system where we can have students actually go in there and practice within different types of forms. But it creates work. Someone has to create all that stuff in the computer. So that could be another avenue or a place where people may work. Medical professionals who create or design forms that are going to be uploaded or given to the IT person, who then puts them up there for use. Okay? So those records, wherever you have records, should be kept locked from people. I know for our athletic training program, any of our records have to be in a locked cabinet that only certain people have the key to, because there are physical forms in there and immunization records, and not everybody can be privileged to those. So that's one thing when you talk about having your own facility or having a facility, you have to be able to manage those records and keep those secure. Okay, so those are the kind of things. Some of the contents may be prescribed by law, some of it may not, but keep in mind, all of those records can be used if you ever get sued or if in legal cases. If you treat patients that have been hit by car accidents or in the midst of a legal case, all of those records are probably going to be subpoenaed and requested when you go to trial, which means you have to be careful about what you put in there and how you put in and how you say what you put in there. So we use medical records obviously for communication between diagnosis and treatments between different healthcare professionals. There are lots of places that will use those medical records for research. If you talk about the CDC, if you talk about the National Institutes of Health, they will pick and choose and survey and go through longitudinal data to find trends in healthcare and things like that with medical records. Currently, the United States has a national injury surveillance where high schools report all their injuries to a specific data so that we can get information on, who gets what type of injuries, how many concussions, at any particular age, and all those other things. So there's tons and tons of data that can be out there gathered from those if you're interested in doing that kind of work and finding those kind of trends. Reimbursement records, how much reimbursement you get for different types of treatments. If you are the owner of the clinic, you certainly want to know how much Aetna is paying for traction and how much you are getting for each of the different types of services. So is it worth my time that I have to spend doing manual therapy to only get $12 from Cigna or $12 from Aetna, or maybe I should only do that with my Blue Cross patients because I'm going to get $60 from Blue Cross. But the only way to know that is from going back and looking through those medical records and finding some trends. So there's some good uses for them. Then the other thing, the last thing, is for legal defense. Anytime something happens, legal case or malpractice, or if somebody just decides that you didn't get them better, and they want to take you to court because they spent thousands and thousands of dollars and they're not any better than they were before. The article I just saw in the newspaper today was just about the costs and the fact that a lot of the Obamacare health care programs come with very high deductibles. So that means you pay, let's say you pay $10,000 a year for your health insurance, but in addition to that premium, there is what's called a deductible. And some of the deductibles are like $3,000, $4,000, $5,000, up to like $6,000. So that means not only are you paying your premium every month to have the health insurance, but you have to pay that $6,000 out in medical bills before your insurance will even kick in. Because some people are questioning, what is the point in having that type of insurance? Nobody is any better off than they were before because we're still having to shell out $6,000 and $7,000. Do you know that bankruptcy is the #1 reason why people go bankrupt? They lose their house and their car, and they stand on the side of the road. I saw a very innovative sign this morning, first time I've ever seen it. Guy was holding up the sign that said, I'm an alien.
I
I need a
dropped
taco.
off by
Dropped off by alien. I need a taco. That's the #1 reason. I thought that was pretty innovative when Michelle did that. She's so cynical. She's like, that's old. But I've never seen it before. You guys.
It's on Facebook last week from a tow truck driver that drove by.
So apparently, I just first time I saw it. #1 reason why people go bankrupt.
Gambling.
Gambling's a good choice, but not the answer.
Student loans.
Probably not the good answer since we're talking about medical records. The student loans might be at #2. Medical illnesses. People get some type of catastrophic injury or illness and can't pay their medical bills, and next thing you know, they're losing their house and their car. All right. So there are lots of different types of medical records that you are going to be exposed to. In this class, for this project, you are going to create some type of medical history form, because if you're going to prescribe exercise for people, then you need to know if they have some type of conditions, right? If you're in cardiac rehab, at the bare minimum, you're going to do a Part Q on that, okay? So, in here, you will be allowed to use the Part Q because that's the gold standard when you're talking about cardiovascular exercise. If you have a high school facility, you will be allowed to use the Ohio High School Athletic Association physical form because that's the gold standard. Nobody else uses anything other than that in high school. If you're going to do physical therapy or you're going to own your own gymnasium or whatever, you need to come up with some type of medical history form. Now, you don't have to sit there with a blank piece of paper because there are examples that I have uploaded for you in Springboard in this particular module. There are some in the back of each textbook, And if you Google medical history form, I'm sure that you can find 200 of them. You can use them as resources. You may not cut and paste them. If you cut and paste them and I catch you, you will wind up in judicial affairs. Okay? And I don't want that and you don't want that. So use them as references. You don't need to reinvent the wheel, but use your own elements for your own type of facility. Andy?
I'm not sure about Pilates, but I've never filled out one for yoga.
No, but you should. What if you had a total hip replacement and you're going to Pilates and they're doing some kind of bouncy stuff and your hip joint comes out of place?
Isn't that your fault?
Is it my fault?
No, mine. Would it be my fault?
It would be your fault. Are you talking about being the owner?
No, I'm just saying if I had the hip replacement and I went, would that be my fault? How is it theirs? You know.
Because as soon as you walked in the door to do any type of exercise, they're responsible. And you could sue them. I have total hip replacement. I'm feeling good. I can do all the activities of daily living that I want to do. Why shouldn't I be able to go to Pilates or yoga? Right? But they should ask you, at the very least, and again, you don't have to create some elaborate 20-page form, but at the very least, if you're going to prescribe exercise for someone, don't you want to know where you're starting with them? How are you going to know if you're any better with them than when they came in if you don't do some kind of basic evaluation? Fit principle, flexibility, endurance, strength, endurance, blood pressure, height and weight. Wouldn't you want to know if they had a total hip replacement if you were going to do any kind of exercise with them? Even if you're going to do physical therapy and they're there for your shoulder, I might put them on the bicycle to warm them up, or I might put them on the treadmill to walk. So I want to know if they had osteoarthritis, so I choose different activities. It helps you, not only does it protect the patient, but it helps you be able to be professional and design things that you want to do. Don't get me wrong, there are tons and tons of places that don't do it, but remember, once you have an education and once you know better, you have to be better. You have to go to the standard.
Is it okay to ask somebody about bloodborne pathogens on your
What do you
screening
mean?
sheet? Like ask them on the sheet if they have HIV or Hep B or anything like
You
that?
can. I wouldn't ask them personally, but you can put it on a checkbox form that says blood diseases or family history.
Because that, if I owned a facility, that'd be something that I'd be worried about if somebody gets injured, and then I would want to know whether that person has a disease so that I know what kind of precautions to
Right.
take with them.
That's exactly. But not only that, but there are tons of other things other than just HIV that, the chances of that are pretty slim, but the chances of someone dying of a heart attack are much greater than you contracting HIV. So we're talking about conditions and things that, one, you should know about so that you're prepared with your emergency action plan, and two, so that you can be a good professional and prescribe the right type of exercise for the right type of person. Are you going to, have your 90-year-old lady do a squat, with a bar to see how strong she is before you prescribe exercise for her? No. I don't know. There may be some 90-year-old, there are 70-year-old people that run marathons, so there may be some 90-year-old powerlifters. But it's the appropriateness for whatever type of facility that you're doing. And, like Josh talked about, he does a movement screening to see, he's not going to put people in some advanced movements if they don't have some basic foundational strength, because you're asking for a problem. So, to be prudent, you do whatever screening that you feel like is necessary for your type of facility. And again, there are examples in your chapter, both textbooks, there are chapters about screening, and I believe that I actually even copied the textbook chapter from a different ACSM textbook that gives you all the guidelines about screening. If you're a personal training person and someone is going to come to you for strength and weight loss, don't you think you want to do a body comp on them to see, and some waist measurements, not BMI measurements, but so that you can show that they've lost 2 inches off their waist or 2 inches off their thighs? Do you think you might be able to help meet their goals that way, and that might be part of your program? Yes or no? Yes. Right? So not that comprehensive. Again, we're not reinventing the wheel, but we're using our brain and our ideas and our thoughts with what's already been done. Okay? And again, there are examples, all kinds of examples provided for you. So, different types of medical records also that you may want to include in your facility. Again, these are important for professional practice, but these are also some ideas in that midsection where we talked about the fact the exercise science elements and the athletic training elements. If you don't know what to put in there are going to be some ideas in here about different types of medical forms you can create, or different forms that you can create that are going to help your business run the way it's supposed to. So, the first type of medical record is a SOAP note. Anybody in here not heard of a SOAP note? Absolutely fabulous. Now, the problem with SOAP notes is that most of us aren't very good at writing them. Believe it or not, they're very hard to write well. And they're very hard to write well unless you practice them, unless you do them over and over and over again. Because the right information has to get in there. So we have subjective information that you either see about the patient or the patient tells you when they walk in. How are you feeling today? My right shoulder hurt when I woke up this morning. Okay, something that can't measure, but something that they are telling you that is going to be part of their treatment. And you have to be careful in there too, because when insurance companies go to pay you and they look at these SOAP notes, the diagnosis that you are treating the patient for has to match up with what you're saying in the SOAP notes. So, you have to be careful, particularly if you're talking about legal cases and workers' comp cases. If the person's saying they can't go to work because they got hit by a car and they're in the middle of a lawsuit, but yet they're out mowing their lawn and they're doing other kind of things, you have to be, be careful about that in what you write and how you say it. Okay? Objective, that's information that's obtained from some kind of number, some kind of thing that you can show progress from. Goniometry, ranges of motion, girth measurements, biodex testing numbers, where you can actually test the strength of their hamstrings or their quads. Anything that Charles can do, that James can reproduce, and you can get the same information, or can be, I run into that all the time. It's one around on my black and blue. Anything that can be shown to provide progress and documented numbers. Assessment, your professional opinion based on the subjective and the objective. So, what is my assessment of the patient here today? Patient has made progress on their shoulder, increase in range of motion, but still can't wash her hair. My assessment. So my plan is going to be to work on activities that are going to be over her head so that she can be able to wash her hair and comb her head and reach out of the cover. Okay, specific information. And those of you that are going to go to PT school are going to write those until you're blue in the face, probably. Because those notes get sent to the insurance company in order for you to get paid. So you don't want to have to send them. Even though we send things electronically now, instead of via snail mail, where you used to have to send everything, print them out, and send it by stamps, and it would go to the office, and then they would reject it, and they would send you a rejection back, and then you have to do it all over again. And that costs money and time. Now it's a little bit less money because of electronic medical records, but every time that those get rejected and they come back to you, do you get paid? No. So you treat the patient today, your billing records go out 30 days from now, it goes to the electronic place, they weed through their 2 million records, and then they pay you. I mean, you're talking 3 or 4 months out before the time you treat that patient before you get paid. That's a long time. Okay? So the better your notes are straight up, the sooner you get paid, and the better chance you're having to get additional visits for that person. Okay. Some other types of things out there, treatment logs. These are most commonly found in some athletic training settings where you want to document the treatment of patients, whether you did ice, heat, ultrasound, stim, stretching. They can be physical therapy, occupational therapy, whatnot. I encourage you to try and not have blank pieces of paper that just boxes that you have to fill out, because if you're seeing more than one patient at a time, or if you're seeing patients back to back to back, the chances of you sitting down and writing exactly what you did get very slim, and the chances of you remembering at the end of the day after you saw 25 patients, you're just making shit up, because you can't remember from 5 hours ago exactly what weights you used on which person and how many sets they did and how many reps they did and what order they did the exercises. So it would behoove you to try, particularly if you have specific protocols for shoulder rehabilitation, or if you have specific protocols for your overweight 45-year-old woman who comes in and you're starting them on a flexibility plan first, to have some check-off boxes or have some things where you can just X off and not have to handwrite everything out, because it takes a lot of time. Parents and coaches notes, anybody that's going to work in OT, PT, athletic training, chiropractor, and you're going to see high school athletes, you're doing yourself a favor if you communicate with the coaches and the parents in written form. Okay? It's like the telephone game when you tell a 14-year-old or 15-year-old or 16-year-old what you say to them, what they hear is one thing, and then what they repeat to the coach is a totally different thing. And so in order for people not to be doing activities that they shouldn't be doing, or doing, or being held out when they should be participating, and again, those can also be semi-form letters where you can fill in what your diagnosis was or what you found and the parameters in which they're allowed to practice. You'll save yourself a lot of headaches if you do those. A pre-participation examination, there are some pretty gold standards for those. I know here at the university we have a gold standard. Everybody uses the same one. I mentioned the Ohio High School one. And those are comprehensive medical screenings that do your whole entire body. They do everything from height and weight, blood pressure, to a musculoskeletal exam, to the, cough and turn your head and cough, to growth and development. They encompass everything for participation because they want to make sure, the physicians want to make sure that they're not putting you out there in a position to be compromised, where you're going to get injured even more. So pre-participation examination is an exam where people are going to participate in types of activities. Activity screenings are different. An activity screening is, what information do I want to know before I allow my patients to do some kind of activity? Not necessarily athletic participation, like at a high school level or collegiate level, but physical therapy, at the gym, at the cardiac rehabilitation. What kinds of things do I want to know? And those typically involve your flexibility, muscular strength, muscular endurance, some body comp, basic principles of fitness. The PAR-Q is the gold standard in terms of cardiac rehab. The other kinds of things, records that we want to talk about are consent forms, consent to participate, which means I'm saying that I'm allowed to participate and I can participate knowing what I know, and also waiving of your consent that says I'm signing this waiver and I know that I might not be fit, but I'm going to do it anyway. And the most important thing that you can do if you learn nothing and you sleep through this whole entire lecture today is to write things down. You can never be wrong if you document what you do. No matter how simple or how skimpy it is or what kind of form it is, the best thing that you can do for yourself and for your patients, if we go all the way back to the very day one when we talked about those American College of Sports Medicine standards and we talked about providing a safe environment for your patients and for users to be satisfied, if you did those two things you probably wouldn't get sued, is to write, and again, you don't have to write everything down, but you have to write the important things down. When you treat someone, when what kinds of treatments you do, particularly if they say they're not feeling well or if something just doesn't sit right in your gut about that, write it down and put it in their chart. You'll be doing yourself a favor. We already talked about medical record software. We already talked about computer storage. One thing we didn't mention, but if you are going to have computer terminals out among your patients in their patient area, or people are going to be there, then you have to have, or you should have, one of those screens that goes over your computer screen that blurs everything, so other patients can't stand over you and say, oh, Jane Doe's on Prozac, and then they go tell two friends, and they go tell two friends, and they go tell two friends within that clinic. So make sure that you are careful who has access to the computer and where they have access, and if they are, that it gets blurred up. Okay. A couple of different legal terms before we actually get to the whole legal issues about liability and things like that. There is a statute of limitations in terms of keeping records and also in terms of bringing a lawsuit against someone. It depends on which state you live in, but typically you need to keep medical records, for about 1 to 8 years, in the physical therapy type of setting. Okay. So also that leads to the fact that you can only file a claim within a certain amount of time. And I want to say for car accidents, I want to say that it's a year. Like if you get hit by a car today and you're fine, but then over the next 6 months or 8 months or 9 months or a year, you decide that, oh, now you're having all these problems with your shoulder and your neck, and you think it stems from the car accident, you have to file that claim, I want to say, within 12 months in order for it to be valid. Just like statute of limitations. Just like if you kill someone, there's no statute of limitations. You can murder someone today, and 50 years from now, if they hunt you down and find you, they can try you for murder. Not so with legal cases and medical records and things like that. Okay? But it depends on which state you practice in. Okay? Legal use of records. Medical records typically are used for the baseline. They establish what you did to the patients and what you told the patients. And that's equally as important. If you don't tell the patient, imagine going in for surgery and you're supposed to have a total knee replacement and the surgeon doesn't tell you that there's a chance that you could lose your leg. And you come out and you don't have a leg. Do you think that that's going to be a legal case? Absolutely. But that is a possibility. Something could go wrong in there during the surgery and they could find something horrible. Maybe they found a tumor in there that they didn't know, or maybe the pieces were so messed up that there was no way that they could save the leg, particularly if you were in, car accident or some kind of traumatic accident. So you have to make sure when you put that person on the treadmill, you have to tell them all of the things that can possibly go wrong. The fact that they could fall off the treadmill, the fact that they could get dizzy, okay? The fact that they could have a heart attack. You don't want to scare them, but you want to make sure that they understand the risks of what is being done to them and what can happen. Anthony?
Do you have to tell them that every single time that they come to see you?
You should remind them. You shouldn't have to go through a 20 or 30-minute dissertation.
Yeah.
But the very first time that you do different exercises or activities with people, you should explain to them exactly what is going to be done to them, what sensations they might feel, and some things that can happen. And that's one of the reasons why, particularly in athletic training, we do so much clinical work, because you have to get good at talking to people. You have to get good at answering questions when people ask you questions. Same thing why Rochelle does practical exams and why she does stuff in exercise prescription, where you actually have to get across from somebody and motivate them, and actually have to touch a patient when you do exercise testing, practical and things. Because you never know what questions they're going to ask you, and you think you know what's going to happen during that particular session, but we don't have crystal balls, so we can't know for sure. As I will tell you, there have been all kinds of things that have happened. Again, I have stories, about the patient that dislocated his shoulder. I tell you the story. We had a patient who was a neck patient, and he was on his last day before he was going to be discharged. He was going to be discharged that day, and so we were taking him through his last bit of exercises, and we used to use the pec deck machine where you sit like this and go forward like this, but we would use it reverse. So we would put them this way and put their hands inside and go like this to work the rhomboids instead of doing weight machines. Well, nobody knew that he had a history of shoulder dislocation. So what do you suppose happened when we put him up here like this and we put some weights on that stick? Clunk. Right out. That's awful. First of all, it's awful to be standing next to him, when it happens. Second of all, you start, all your brain starts to go, do we know that he had a history of shoulder dislocations, blah, blah, blah. Did somebody find out or whatnot? So, bad things can happen even when you think that they won't and when they can't. We eventually put him we had to take him downstairs to the, at that time it was like one of the rapid response type places, and it took like 5 people to get his shoulder back in with all the different traction and things like that. And then he became a shoulder patient, unfortunately, for a little bit before he was discharged. But those are things that if you should have done a pre-existing questionnaire to find out if he had a history of shoulder dislocations, because the exercises that we were going to prescribe for him would not have included that had we known. And the question is, do we ask him the right questions? I have a story for everything, so those of you that haven't had me for class before, all kinds of things have happened to me, except for being sued and except for someone dying on me. So, make sure that the medical use of records is not only what you write in the chart, but what you tell the patient and what the patient remembers what you tell them, because that's different, okay? And again, they are confidential. They are subject to federal and state laws regarding confidentiality and content. There's all kinds of rules about that. So, there are some standards when you document things that have to be included. I gotta talk a little faster, we're gonna be here forever. So, there are some standards that have to be included. And this should be good practice for you as clinicians. The fact that the services that you're doing are supposed to be medically necessary. You're supposed to be performing things that are prescribed and known treatments for their particular injury. Okay. The fact that you are a skilled caregiver, the fact that you have the education, the experience, and the licensing in order to be performing the treatments that you are supposed to be doing. Hence the reason that people have licenses so that they can use those. Now, if you're sitting there, you're asking yourself, well, what about the aides that work with me? That's what I'm thinking, because if you've ever been to a physical therapy clinic, there are PTAs, which are PT assistants, physical therapy assistants, who have gone to school, and then lots of places will hire college students to be aides. Right? Say yes. Either you may have seen them on your practice. So, are they still caregivers?
Yeah.
Bruce says yes.
No.
Someone else in here surely must say no. Anthony says no. But what qualifies them to be able to provide care? What's the difference? What's the qualification or the qualifier
Because
there?
they're under supervision of somebody who's qualified.
Because they are supervised. But that's a very big, what are these called? Quotation marks and quotations. They have to be supervised in order to be able to do that. Because, again, when it comes back, if they get hurt and there's nobody watching them, or the only person watching them is the aide, and the supervisor is eating their lunch in the back and nowhere to be seen, think the patient's not going to know that? Okay, so make sure that you're doing what you're supposed to be doing. Significant progress. People have to make, the treatments that you are doing with them have to cause improvements within a normal and reasonable amount of time. I don't know what normal is. Who can tell me what normal and reasonable is? What is a normal and reasonable period of time?
It really varies based on the injury, the condition, the patient.
Absolutely it does. Anthony?
Okay, I'd say like most low ankle sprains, you should be better within about a month, like depending on the person and how hard they work at.
But it says significant progress. It doesn't say anything about lower ankle sprains in there.
So it's, or whatever, I'm saying just like as an example, something like that, there's a certain time where, I don't know, I feel like.
How do we define that certain time? How do we define what's normal and reasonable? And who defines what's normal and reasonable? Never?
The jury of your peers.
A jury of your peers? You hope it's not a jury of your peers. If a jury of your peers is deciding that, then it's too late for you. And you're already going to be in the cheese line. Or you're going to be spending a lot of money keeping yourself out of the cheese line. Who defines what's normal and reasonable?
Insurance companies.
Insurance companies?
ACSM.
ACSM, if you're talking like that. Physicians?
Board certified on big
AAOS,
panel.
American Academy of Orthopedic Surgeons. People above you decide what is normal and reasonable. Now, that's a very sticky widget, because what James thinks is normal and reasonable, Mariah might not think what's normal and reasonable. But there are standards when you treat patients, and Medicare, as you'll see when we start talking about medical insurance, if you're going to be paying by insurance, Medicare decides everything. Whatever Medicare decides, everybody else follows along their merry little way. So, particularly with Medicare patients, people have to show progress. It gets really hard to show progress in the 90-year-old lady with the posture problem like this when you're seeing her 3 days a week. How are you is she gonna make enough progress? Let's say you see her on Monday, you don't see her on Tuesday, you see her on Wednesday, you don't see her on Thursday, and you see her on Friday. What kind of progress is she gonna make between Monday and Tuesday? Or between Tuesday and Wednesday? Or Wednesday and Friday? So that's one of the challenges is, how many visits do you get from the insurance company? What kinds of activities and things can you do with them that's going to show improvements, and that you can know that you're doing right by them and providing them treatments that are medically necessary. And it's a balance every single day and a juggling act every single day. But I will say that you have to be careful is that, insurance companies and things, they set up norms. So if you have an ACL tear, they say you should get 60 visits, which is not true anymore. They say you should get, 45 visits. Some insurance companies will tell you get 45 visits. Some insurance companies will say you can be seen for 3 months. Some insurance companies will say you can only do exercise. And so some places set up parameters, and you have to work within those parameters, and it gets really challenging to be able to do all of these things. Medically necessary treatments by a skilled caregiver that shows progress, that shows that whatever you did was quality in the care that you were given over the course of the whole entire rehabilitation. So in reasonable intensity, which means you can't, hardcore right away and, hurt them any worse than when they came in. So those are the standards that you're supposed to be held to, which are challenging, particularly when you talk about noncompliance with patients because they're life scenarios, particularly when you talk about restrictions from people getting to your place and insurance companies and other things. All right, so what kinds of things, if you are sitting at home with your blank piece of paper and you have no idea what to put on it in terms of documentation, the first thing that you should do is think about what things you want to know. If I'm going to be a physical therapist and I'm going to treat someone no matter what condition it is, what is the very bare minimum that I need to know about that person? And these are easy. Your name, your address, obviously some height and weight and body composition, blood pressure, resting heart rate. Those are things that you should know about every person. But if you're looking for other things, CC means chief complaint. What is the reason that they are there to see you today? What is their chief reason or their chief complaint? When did they have their incidence of whatever injury it was? And again, if you are prescribing exercise for them in terms of personal training, there is no time and date of incidence because they probably didn't get out of shape or heavy. They didn't get to be 250 pounds overnight, so there's no date and time of incidence. Do they have some signs and symptoms? If they don't have signs and symptoms, then what is the reason why they're there today? I want to lose 40 pounds. I want to get down to 20% body fat. I want to run a marathon. Whatever it is. I want to get in a little black dress for whatever reason. Okay, so why are they there? If they've had any treatment before, what is your plan of action going to be? I would make sure that you know if people are on medications, particularly if you're going to do high level intensity exercise with them. If you're going to put them on a treadmill or a bike, or they're going to run or do anything where they're going to be doing Valsalva or they're going to be doing something that's high level, high intensity work, you better know what kind of medications they're on in case they pass out or in case they have some interactions. Okay? Have they had any MRIs, CT scans, bone scans? Have they come from a physician with a signature and then your signature so that you say, yeah, I saw them and I asked all this information and this is what they told me, whether they're lying or not. Okay. So, why do we do activity screening in terms of medical records? How do we tie those two together? Well, because we don't want people dying on us when we're there, which leads to ruling out life-threatening or disabling conditions. We can help prevent diseases or disorders or problems down the road. If we do hamstring flexibility before we start with them, then hopefully we can rule out some of those. We might be able to detect some things in them. Maybe they haven't been feeling all that well, and as we start to talk with them, we find out that maybe they have some kind of long-term infection or something, or maybe they've got symptoms of Crohn's disease or whatever that they didn't tie together, and you can refer them to the right place. You're meeting your legal obligations to make sure that you ask the right questions so that when something happens, you don't say, oh yeah, well I never asked them if they had a history of heart disease. I never asked them if their dad died, when he was 40 of a heart attack before I put him on the treadmill. You don't want to have to ask that person. To determine what kind of health they're in already, are they even in good health to begin with? If you want to have some kind of counseling sessions related to health issues, if you're a personal training place, or if you want to refer them to nutrition counseling or smoking cessation, or maybe some, life coaching, which is the new latest and greatest profession, life coaching people. They're called life coaches, not psychologists, or maybe they're still psychologists, but now we have this whole sector of people. I want to say right across the street, there's psychic/life coach that you can, I'm not sure if they're an exercise science person, but somebody maybe couldn't get a job, I don't know. But there's a whole other realm of life coaching and getting yourself organized and all those other things, and certainly to assess their fitness levels. We can't tell them if they're any better than they were if we don't know where we started from. Okay? Pre-participation examination, this is directed a lot for high school purposes. This is not intended to be a substitute for regular doctor visits, but a lot of times in the high school it is. Sometimes in the high school this is the only time that people will see a physician. or interact with the physician, particularly if you're talking about inner city or particularly if you're talking about rural areas where there are lower socioeconomic classes. Not that it doesn't happen in suburbia, but a lot of times that will be the only time that people will see the doctor. Keep in mind, the purpose for pre-participation examinations is not to tell people that they can't play. That's not the purpose. We want people to participate, but we want people to participate safely. So we don't want to put people up there who can't protect themselves or who are going to put themselves at risk. There was a boy when I was at the high school who only had one kidney. And so he was not allowed, I'll never understand this, but he was not allowed to play football. He was not cleared to participate in football except to be the kicker. But he was allowed to play soccer. Yeah, I don't know how that worked out. But for those of you that play football, what happens if the holder fumbles the snap? What does the kicker do?
Runs for his life.
He picks up the ball and runs for his life. And so the chances of him getting tackled are pretty high. So I never understood that particular thing. But so in order to promote safe participation for that individual, he was not allowed to play anything on the field other than the kicker. So some statistics about people: only 0.3% of people that play sports are ever denied clearance. But we do have this category, anywhere from about 3% to almost 14% need some kind of further evaluation. Most times that is cardiovascular. And if you haven't heard about sudden cardiac death in athletics, it's a huge topic, only second to concussions now in terms of evaluation and further evaluation, the ability to diagnose and detect conditions. And so if something gets picked up on the EKG, for those of you in exercise science in here who have read EKGs, right? You don't know what the hell you're looking at because you didn't do so well on the test. Then you refer them to someone who does know what you're doing. All right. Here are some different things about pre-participation examinations and things that you can do. Typically, a lot of times the athletic training people are in charge of running them in the high schools. They can do them, you can do mass ones. Most of you that play high school sports in here probably had some kind of mass physical where you go into the room and you go through the little station area. It has advantages, as does going to your own physician also have advantages too. And here are some of those where you're doing station-based or physician's office, goods and bads. Now, the best thing that you can do as part of your activity screening is take some kind of general medical history. Okay? Your textbook says that, the textbook says that it's the cornerstone. Medical history is the cornerstone of any medical evaluation. If you ask the right questions, you can learn, I will contend, that you can learn 80 to 90% of information from people in that medical history that you will need to treat them for a continuum of care. But if you don't ask the right questions, then you don't get enough information, and then people are at risk. So the other question is, when you're dealing with high school athletes, and this, even if you're in the PT clinic and you're working with high school athletes, if you ask athletes to complete a medical history and you ask their parents to complete a medical history, about 40% of the time they won't match. So what the kids know about themselves is one thing, what the parents know about them is another thing, and a lot of times they know different information about each other. Things that happen to, or health issues related to adolescents maybe that they're not sharing. So you probably need to know both, or have some questions for both parties that have some baseline questions. Screening tools, here again are some components. You can see all these components in some of the forms up in there, so we don't need to talk about them. There's a couple different ways you can clear people: free and clear, clearance after further evaluation, or not cleared at all, not participate at all. But one of the things that is happening now is that we have athletes that are coming to participate in sports with many more conditions than before. Where we used to have some with diabetes, now we have diabetes, and we have Crohn's disease, and we have sickle cell disease, and we have asthma conditions and restricted airways. So a lot more systemic conditions that athletes are participating in that we better know about, and we better know what care they're receiving so that we can address any of those issues. Okay? American College of Sports Medicine has a position statement for activity screening. If you're going to be in NACSM, you need to make sure, this one right here, recommends screening for all people. You got to do something. Something has to be on paper. I don't care what it is, but all of you at this point in your career, with the coursework that you've had and the experiences that you had, should be able to decide what you want to know about your patients before you exercise them. Okay? And obviously, the American College of Sports Medicine is most concerned with cardiovascular disease because that's what they do. But you should touch on all phases, for metabolic diseases and others. Okay? Here are some startling statistics for you. There was some research done. I think it's on the next slide as far as who did it. About ACSM screening, 15,000 health and fitness facilities. About 40% of those facilities do not use a screening interview or questionnaire. That's a lot. That means they're asking no questions. Here's my swipe card, 24/7 fitness, and I don't mean to pick on them if any of you belong. But here's my swipe card, 24/7. I'm going in, I'm exercising, no supervision, no health questionnaire, in, out, whenever I want. 2, 3, 4 in the morning. So, 10% of those, no initial cardiovascular health screening or anything at all. So, no questionnaire. And again, ACSM, everybody should do some kind of screening for new members. Obviously, we want to know who's at risk and how to prescribe exercise down the road. We could have a big argument or discussion about EKGs and their effectiveness. It is still a very topic in the news in terms of cardiac screening for high school and collegiate athletes, whether or not it's cost effective for us to do EKGs on every single athlete who participates, high school or college. And I went to the American Alliance on Youth Sports last February, which is a place where there are parents there who have had sons and daughters who have died from different diseases or disorders, who have started foundations. There was a lady there whose son was heat illness. There was another one whose son was hit in the ribs. Wide receiver went up for a pass, and somebody helmeted him in the side in internal injuries, just so much internal damage, and they actually have this special pads that they've created for rib guards. There's another family whose son or daughter died of cardiovascular disease. So at this Youth Sports Safety Alliance, they come together to try and find how can people participate, how can we protect people from participating better. And so one of the questions, there's one place where they do cardiac screening out in Seattle, and they have a line out their door. They can only take so many people, but they've had so many people that have died of cardiac death that they feel like they get donated physicians and EKGs and all that, and they put everybody through a cardiac workup. But in the reality of where we live and where we work, can we do that and be cost effective, and should we do it? Which is still a debate. And we talked about the PARQ. Doesn't identifies a little bit of musculoskeletal, but mostly for any kind of heart disease. One page, you get some history and some symptoms. Risk factors are the big thing with ACSM in terms of is somebody at risk based on what their history is. Okay. All facilities should provide supervision. You should have some kind of physician referral form if people are going to exercise, and you should have some kind of release for medical information like you have the document. Rosie, Ruthie, I don't know who Rosie is.
I feel like at the Y, when I've told some people fill out their questionnaire and they have to get it cleared by a physician, their response is kind of like, oh, that's not going to happen. Sorry.